Welcome to the Explainer. Okay, let's dive right in, because today we're going to decode the abstract, and let's be honest, sometimes intimidating world of pharmacokinetics. But don't worry, we aren't just going to sit here and stare at dry formulas or textbook definitions. We're going to explore exactly how these concepts play out in the real world. Guided by our source material, the ADME microlecture structure, we're going to ground the science in a very real, very complex clinical scenario. If you've ever wondered how extreme physical stress fundamentally changes the way our bodies process medication, well, you are definitely in the right place. Let's get started.
Picture this. This is the central mystery we're looking at today. You've got a 68-year-old patient who has just undergone major cardiothoracic surgery, specifically a coronary artery bypass graft, or a CABG. They receive a completely standard, totally by-the-book intravenous dose of a sedative, but instead of waking up when they're supposed to, they remain heavily sedated for hours. Why? What actually happens when a normal, everyday drug dose meets extreme physiological stress? Keep this patient in the back of your mind, because solving this mystery is the absolute key to understanding today's topic.
Here's our roadmap for this explainer. We're going to track the journey of a drug from entry to exit using the ADME framework. That's absorption, distribution, metabolism, and excretion. And finally, we'll quantify the clinical impact on our post-op patient.
All right, Section 1, the journey of a drug, or what the body does to the medicine.
First off, it's absolutely crucial we separate two terms that get mixed up all the time: pharmacokinetics and pharmacodynamics. Pharmacodynamics is what the drug does to the body. You know, how a blood pressure pill interacts with your cells to actually lower your blood pressure. But pharmacokinetics, or PK, is what the body does to the drug. It's literally the study of how your body interacts with an administered substance for the entire time it's hanging around in your system. Understanding this is what gives practitioners the superpower to maximize a drug's therapeutic benefits while dodging the risk of toxicity.
So the core of all this is a simple four-step pathway. ADME. Absorption is how the drug gets into the bloodstream. Distribution is where it goes once it's in the blood. Metabolism is how the liver and other organs chemically tweak it. And excretion is how it ultimately gets kicked out of the body. Normally, these processes dictate exactly how much drug reaches its target and how long it stays there. But as we're about to see with our postoperative patient, when the body is under the massive stress of surgery, the normal rules of ADME, they just completely fly out the window.
Moving to Section 2, absorption. Reaching the circulation, or simply, does the drug actually reach the bloodstream?
This whole step is all about the route of administration. Taking a pill orally is a notoriously arduous journey for a drug molecule. Think of it like a brutal obstacle course. It has to survive the extreme acidity of the stomach, get picked up by specific transporters in the gut, and then survive something called hepatic first-pass metabolism. That's where the liver might just chew up and destroy a massive chunk of the drug before it ever even sees the general circulation. The percentage that actually survives this trip is called its bioavailability. Now contrast that with an IV injection. An IV bypasses the absorption step entirely. The drug arrives virtually instantly in the systemic circulation, which means IV bioavailability is, for all intents and purposes, 100%.
And you know, this perfectly illustrates why our post-KABG patient was given an IV drug in the first place. Right after major cardiothoracic surgery, a patient's whole physiology is in a state of systemic shock. The body goes into survival mode and actively redirects blood flow away from the gut to protect the vital organs, a state we call gut hypoperfusion. On top of that, GI motility just slows way down, sometimes stopping entirely, in a condition called post-op ileus. Because of all this, if you try to give an oral medication, absorption becomes wildly unpredictable. You literally have no idea how much drug will actually make it into the blood. That's why critical post-op drugs are always given IV.
Section 3, distribution, plasma or tissues. Basically, where does the drug go next?
Okay, so the drug made it into the bloodstream. Now it distributes into the plasma and tissues. Three major factors control this spread. First is tissue perfusion. Basically, organs with high blood flow get the drug the fastest. Second is solubility. Highly lipid-soluble or fat-soluble drugs can easily slip across cell membranes and hide out in tissues, whereas water-soluble drugs tend to just hang out in the blood and extracellular fluid. Third, and this one is huge, is plasma protein binding. Drugs floating in the blood love to bind to proteins like albumin. But here's the catch. If a drug is bound to a protein, it's trapped. It's totally inactive. Only the free or unbound drug can cross membranes, trigger target receptors, or actually get eliminated by the body.
Now, distribution does not stay neat and tidy after cardiothoracic surgery. Look at the sheer chaos here. During surgery, the patient gets massive fluid loading, which dilutes the blood. This literally increases the physical space that hydrophilic or water-soluble drugs can spread into, totally throwing off their concentration. Plus, these patients often have low cardiac output, meaning poorly perfused tissues just aren't getting the drug. On top of that, post-surgical patients usually see a drop in their albumin levels. Lower albumin means fewer protein seats for the drug to sit in, causing a sudden, massive spike in the active, free fraction of the drug. That alone can dangerously amplify its effect. And if they were on a cardiopulmonary bypass machine, that external circuit changes plasma volume and can even trap drugs inside the plastic tubing. Bottom line, the exact same standard dose does not equal the same concentration in a post-op patient.
On to Section 4, Metabolism. Processing the drug, which really means making the drug easier to eliminate. The liver is the undisputed heavy lifter here. Its main goal in life is to take a lipid-soluble drug and convert it into a water-soluble format so the kidneys can easily flush it out. It usually tackles this in 2 phases. Phase 1 uses those famous CYP450 enzymes to alter the drug molecule through oxidation, reduction, or hydrolysis. Next up, Phase 2 involves conjugation. This is where the liver literally glues another molecule onto the drug to make it super water-soluble. Now, there's a really common misconception out there that metabolism only turns drugs off. Actually, sometimes metabolism activates a sleeping prodrug, or it might even accidentally create a highly active or toxic metabolite.
And here is a truly fascinating clinical reality check. The liver needs way more than just healthy, functioning enzymes to clear a drug. It actually needs the drug to be physically delivered to it. A totally normal liver enzyme test, like a standard ALT, does not guarantee normal drug clearance. In a post-surgical patient whose heart is struggling with low cardiac output, there is just less blood flowing to the liver. We call this reduced hepatic perfusion. Less blood flow means less drug is being handed over to the metabolic enzymes every minute. This directly stalls metabolism, leaving the patient exposed to the active drug for much, much longer.
Section 5. Excretion. The route out, or how the kidneys filter the blood.
So how do we get this stuff out of the body? While some drugs take the exit route via bile and feces, for most water-soluble metabolites, the kidneys are the primary way out. Renal elimination happens through a few different mechanisms. You've got passive glomerular filtration, where the free, unbound drug just washes into the urine filtrate. Then there's active tubular secretion, where cellular transporters literally pump the drug out of the blood. But beware, there's also tubular reabsorption, where certain sneaky drugs manage to cross right back into the systemic circulation. Ultimately, how well a drug gets flushed out depends heavily on the drug's unique chemical properties combined with the structural filtering health of those kidneys.
Which brings us to Section 6, Quantifying the Clinical Impact. It's time to solve the mystery of our patient.
Let's look at the patient's current lab stats. We already know their albumin dropped from 40 down to 29, meaning there's a lot more free active drug floating around in their blood. But look closely at their renal function. Their pre-op baseline creatinine was a very normal 88. Post-op, it has completely skyrocketed to 215. Because of that, their estimated glomerular filtration rate, or eGFR, plummeted from a healthy level of greater than 60 down to a concerning 27. Make no mistake, this patient is in severe renal distress.
So I want you to think about this for a second. We gave this patient an IV drug, so we bypassed absorption entirely. We know distribution and metabolism are definitely messed up by the surgical stress. But looking at those specific lab results showing an acute kidney injury, which specific ADME process represents the massive bottleneck that directly explains why our patient is still out cold hours later? Did you guess it? The crucial point is right here. It's excretion. The patient suffered an acute kidney injury. Because those kidneys are failing to filter the blood efficiently, there's a drastically reduced rate of renal excretion. The sedative literally remains trapped in the patient's body for way longer than intended. This leads to continuous, ongoing exposure to the active drug, which directly results in that prolonged, unexpected sedation. When you view it through the ADME framework, the clinical chain reaction makes perfect sense.
So how do doctors mathematically measure this bottleneck? They use a metric called clearance. Clearance is defined as the ratio of a drug's elimination rate to the drug's concentration in the plasma. But simply put, it's the specific volume of blood plasma that the body is able to completely scrub clean of a drug per unit of time, like, say, liters per hour. In our patient with the acute kidney injury, their clearance rate has absolutely tanked.
Understanding clearance is a big deal because doctors rely on this exact calculation to figure out safe maintenance dosing. If a patient's clearance drops, the dosing rate has to drop with it. Otherwise, you risk a highly toxic buildup.
And this leads us perfectly into the concept of drug kinetics. Most of the time, drugs follow first-order kinetics. This means your body eliminates a constant proportion of the drug over time, let's say 10% every hour. If the drug's concentration in your blood is super high, your body eliminates a larger total amount. If it's low, it eliminates less. The rate neatly adapts to the concentration. But if the body's metabolic or filtering mechanisms get totally overwhelmed and saturated, like during a massive overdose or in our case, extreme organ failure, we shift gears into zero-order kinetics. Now, only a constant amount, say exactly 10 milligrams, is eliminated per hour, regardless of how insanely high the plasma concentration gets. It's basically a massive, dangerous biological traffic jam.
Finally, all of this wraps up into one crucial number, a drug's half-life. This is the exact time it takes for the drug's concentration in the blood to drop by 50%. Half-life isn't just a random number. It's a direct mathematical result of the drug's volume of distribution and the body's clearance rate. If a drug has a massively expanded volume of distribution because the patient was pumped full of IV fluids during surgery, or if the clearance rate suddenly plummets because of a kidney injury, that half-life is going to stretch out significantly. That everyday sedative, which usually boasts a brisk 2-hour half-life, might suddenly drag out to an 8-hour half-life in our post-CABG patient.
Which leaves us with this final thought. We've traced the ADME journey today, and we've seen exactly how the sheer chaos of major surgery completely rewrites the rules of absorption, distribution, metabolism, and excretion. It's so easy to just look at a chart and order a standard dose. But when extreme surgical stress throws normal drug kinetics entirely out the window, you have to ask yourself a hard question. Are you treating the textbook prescription, or are you treating the dynamic, living, breathing physiology of the patient sitting right in front of you? Thanks so much for joining me on this explainer, and as always, keep questioning the science.